Our opening piece, though, is I'm going to take a few minutes just to acknowledge from a mom's standpoint what postpartum depression feels like. So we've got just a little over 90-second video. I want everybody to...
I'm a terrible mother. What if people find out? I've made a mistake. I'm no good. I don't want to do anything. My baby, she'd be better off without me. I'm a failure. It would be better if I was gone. What am I saying? That's crazy. Something's wrong with me. I can't do this anymore. All I wanted was to be a mom. All I wanted was to be a mom. I don't feel anything. I'm nothing. I'm empty. I'm a robot going through the motions. I can't give up. I can't go on. I want to die. All I wanted was to be a mom. All I wanted was to be a mom. I'm so alone. My baby deserves more. I'm nothing. I'm empty. I'm empty. What if I let the stroller go? What if I drop her? What if I do it on purpose? Oh God, what's wrong with me? I'm crazy. I'm crazy. All I wanted was to be a mom. All I wanted was to be a mom. How much milk has she had? She's starving. I'm a terrible mom. 10 ounces in the morning. I'm empty. How many diapers has she filled? I have to clean the house. I have to clean the house. I can't sleep. I'm so tired. All I wanted was to be a mom. All I wanted was to be a mom.
So just a little bit of an insight into what my moms are experiencing, the moms that come in and are struggling with mood or anxiety disorder. So that's not uncommon. In fact, that's probably the norm of the patients that I'm seeing in my office on a pretty regular basis. Still dear. So do you want me to just...
I can keep going.
All right. I'm just going to like that. All right. So let's talk about a little bit about why this is important. So pregnant women with depression, we know, are already at increased risk for obstetrical complications. So mothers who are struggling with depression tend to have babies who then struggle as well. These babies struggle from right at delivery. We know that women struggling with more moderate to severe mood and anxiety disorders have differences in birth weight, birth length, AFGAR scores. They tend to have higher rates of NICU admissions. They tend to warrant more care just from a neonatal standpoint. These babies, as they grow older, and moms continuing to struggle from a neurocognitive standpoint. They have difficulty with attachment. If mom's unable to care for herself and by proxy has a difficult time caring for her baby, she's going to spend less time just looking at that baby, holding the baby, loving on that child, and that's going to impact an attachment standpoint. So what we see then is that these children have fewer positive facial expressions. They appear more fussy. They have lower activity levels. And this translates into higher rates of difficulties throughout their childhood and beyond just what we would expect from a genetic risk factor. Because unfortunately, we know that these mothers of children these children already are at an increased risk of psychiatric disorders because of the mom's genetic predisposition. But that, even when we take that into account, that goes above and beyond that. These outcomes, however, are not inevitable. So when I have a mom come into my office and you can see the amount that she is already struggling so much. So often she has so much guilt of what harm she is causing or has already caused to her fetus or her baby. However, treating these moms, it doesn't have to be this way. And so early identification, prenatally, throughout pregnancy, early in the postpartum period, we do not have to continue to see these outcomes. And so early identification and treatment is really key. Oh, now we're not in dancing at all.
No.
Uh-oh.
I'm going to close it for a second, let it restart, and I think it'll help the clicker too.
Okay. All right. So, watch this. Y'all have slides. I'm going to pop that open. I'm going to go like this. Thank you, Tessa. All right. So we are on the next slide, guys. So why else is this important? We know that the prevalence of depression and anxiety disorders are the same across pregnant and non-pregnant women. Pregnancy is not protective. Unlike what we oftentimes hear in the media, that pregnancy has all these good feel-good hormones and these moms are supposed to be at the happiest period of their lives. I see all these heads shaking in the front row. Absolutely not. That is not true. It may be for some women, but that is not the case for all women by no means. We know that suicide is the second leading cause of death for postpartum women. In fact, a recent study just came out within the last week or so showing that the highest rates of suicide are actually months 9 through 12 postpartum. So it's not just in those first few weeks that these risks persist. That the highest risk of a woman being psychiatrically hospitalized throughout her entire life is in the 1 year postpartum. Okay? These women are struggling. Thank you. Next slide. All right, so let's do an overview of perinatal psychiatric disorders. I'm going to be talking about mood and anxiety disorders. So what is this? So this category of perinatal mood and anxiety disorders are all mental health conditions during pregnancy and up to 1 year postpartum. That's kind of the standard definition that we're going to be utilizing. This includes mood disorders, certainly depression, bipolar disorder, the most common. Anxiety disorders, so generalized anxiety, post-traumatic stress disorder, panic disorder, obsessive compulsive disorder, again, the most common, as well as substance use disorder. So I'm going to be focusing mainly on mood and anxiety at this point. So here's a kind of an overview of the most common perinatal mood disorders that we see, kind of a comparison of baby blues versus perinatal depression versus perinatal anxiety. So the first column, baby blues, there is lots of normalcy when it comes to baby blues. Something that affects up to 85% of women in the postpartum period is normal. Okay, so just recognize that. In fact, what I tell my moms is that in the first 2 weeks postpartum, they are allowed to be hot messes. I expect them to be a hot mess. That is okay. They had significant hormone fluctuations. They're not sleeping. They're transitioning into motherhood. That's okay. We allow lots of mood lability, tearfulness, difficulty with sleeping. The key, however, is that they're still able to function. They're still able to care for themselves and their baby, and it gets better. It's self-limited. By about 2 weeks postpartum, I anticipate that is resolving at this point. If it's not, if it's persisting, or if the symptoms started after that 2-week mark, we need to be concerned about perinatal depression. So the definition of perinatal depression has the same criteria as a major depressive episode at any other point in someone's life. So more than 2 weeks of mood or mood symptoms, so primarily depression, sadness, or anhedonia, meaning that lack of joy in one's life. We have, again, that increased risk for up to 1 year. And it affects 1 out of 7 of our moms. So huge percentages of our moms are struggling with perinatal depression, about 15%. Because it's difficult to be able to oftentimes separate what a mom who is dealing with depression, because a mom may have lots of somatic symptoms, right? So she's going to have struggles with sleep. She's going to have appetite changes. Her things that she enjoys may change because of that baby. We really need to be focused on what I term emotional symptoms of depression. Mood, anxiety, feelings of guilt, certainly thoughts of death, passive death wish, I'm no good. So what the mom was saying, I always wanted to do this, why don't I enjoy this baby? And certainly any suicidal thoughts. The other spectrum is perinatal anxiety. So that's, again, that spectrum of anxiety disorders. We'll go over a few of those in detail. Again, fairly high estimates. About 10 to 15% of women will also experience a perinatal anxiety disorder. So while there may be overlap between depression and anxiety, there are absolutely subsets of women who are only experiencing anxiety symptoms. And we need to be mindful of that because they present differently than women struggling with pure anxiety, or pure depression, excuse me. Would it be better if I just gave my mama of 3 boys? Yes? Audrey in the back, can you hear me?
Okay, I'm so sorry.
No, you're fine. Here. Also fine here. Mama 3, shut it down. I'm just going to be loud. Okay. All right. Perinatal anxiety. So I already kind of keyed in a little bit about differences with anxiety disorders. One of the primary differences with anxiety disorders is that of intrusive thoughts. What is an intrusive thought? That is a thought that pops into a new mom's mind that she can't get rid of, that is distressing to her, and it tends to kind of ruminate and circle. Most commonly, intrusive thoughts for new mamas include thoughts about harming baby, okay? These are women who have absolutely no intention of harming their baby, but these thoughts pop into their head that are incredibly distressing to them that they can't get rid of. For example, I'll have new moms tell me, I don't want to carry the baby down the stairs because the thoughts pop into my head that I'm going to trip and crush her. I can't go into the kitchen because I see knives and I think to myself, I could have put a knife through my baby. I've had moms tell me I go into the kitchen and I see the microwave and I have a thought, I could put my baby in the microwave. And again, these are so irrational thoughts. They recognize them as irrational and they're incredibly distressing. Unfortunately, because these thoughts are so distressing to women, they oftentimes will then start to avoid their baby as to not have these thoughts. Okay, so you can see where that pathway goes, that if moms are having these horribly intrusive, anxious thoughts, then they start to separate from their baby. What can that do to that relationship with mom and baby? Not surprisingly, in the 10 years I've been in practice, I have never had a mom disclose these thoughts to me without my specific questioning, right? If a mom walked into your office or however you were interacting with these moms, and she says to you, I've had a thought about stabbing my baby with a knife, that sounds pretty terrifying, doesn't it? So of course these women are not they tend to not share. They're very fearful of Child Protective Service involvement. And so the way to get them to open up and talk about this is by doing what I just did. You tell them that it's a normal thing that can happen with women with anxiety disorders, and you give them very specific examples. And when I start to give very specific examples of things that women have shared with me, not uncommon, I start to get head nods and say, yeah, I've had that. Yeah, I've thought about that. I won't give my baby a bath because I think she's going to drown. I don't want to drown her, but I keep thinking that the baby's going to drown, so I won't do that. My husband has to do that. So that's the best way to get at some of these really intrusive thoughts with women with anxiety disorders. All right, so I'm going to talk a little bit about some other anxiety disorders as well. Obsessive compulsive disorder, OCD. So obsessions are, again, those intrusive thoughts, those thoughts that pop into somebody's mind that they can't get rid of. The compulsion piece then is physically doing something to get rid of that thought. A lot of our moms with anxiety disorders who have intrusive thoughts may not have the compulsion piece. If they do, they're probably meeting criteria for OCD. The most classic example is that of a phobia or concern of germs. And so mom thinks something is contaminated, she therefore needs to hand wash. How I've seen this present with new moms is that they're terrified that somebody comes to visit the baby, doesn't wash their hands. Visitor leaves, mom is swabbing that baby down with alcohol wipes, okay? She recognizes she probably shouldn't be swabbing that baby down with alcohol wipes, but she doesn't know how else to get rid of the thoughts about contamination. This can occur certainly prior to pregnancy and can be exacerbated during pregnancy. We also see new onset OCD is not uncommon in the perinatal population as well. Post-traumatic stress disorder. Again, so these are anxiety symptoms that are precipitated by a traumatic experience. Unfortunately, a lot of our women may have a diagnosis of PTSD prior to pregnancy. If it's a secondary to a sexual trauma, that may make their pregnancy, their vaginal exams, their visits throughout pregnancy incredibly distressing and difficult. Asking some of these questions and recognizing that in anticipation can be incredibly helpful. The other thing to remember about PTSD is that the trauma experience is how the mother experiences the trauma, the patient experiences the trauma, not how others experience it. So that comes into play when you talk to a mom about her delivery experience.
I have lots of mothers tell me about their traumatic delivery experience and how they thought their lives were at risk or the life of their baby was at risk. And they can begin to have PTSD-type symptoms, so again, intrusive thoughts, nightmares, flashbacks, about their delivery. I can walk across the hallway and ask the obstetrician, what happened in that delivery room? And the obstetrician's kind of laissez-faire about it and says, nothing. There was a couple of decels, but we had it under control. There was no concern for a crash C-section. Baby did fine, but whatever mom heard or mom was concerned about, she experienced that as a potential trauma and potential harm to herself and baby. What about postpartum psychosis? This is a term that has a lot of concern for those of us who practice in the perinatal population. This is the one thing, a true postpartum psychosis, that will get me out of bed at night and get me into the hospital, because these women have very high risks of killing themselves and killing their babies. About a 5% risk of suicide and a 4% risk of infanticide. What we need to know, however, is that's fairly rare. About 1 in 1,000 women will experience a postpartum psychosis. And there's a bidirectional link with bipolar disorder, particularly bipolar disorder type 1, where women have very high highs and very low lows. So if you have a woman with bipolar disorder, the best treatment for her is management of her bipolar disorder with medications throughout her pregnancy. Hands down, we've seen it over and over again from a research standpoint. Moms with bipolar disorder need management during their pregnancy. So those moms have the highest risk of developing a postpartum psychosis. Now, if a woman who does not have a mental health history develops a postpartum psychosis, what I always say is when the smoke clears, we better be looking for bipolar disorder, because they do go hand in hand. Postpartum psychosis presents very abruptly, so within the first 2 weeks, typically, of a delivery. So if a mom is beginning to experience psychotic symptoms several months later, she probably doesn't have a true postpartum psychosis in the traditional sense. I'm not saying she's not psychotic, I'm just saying that it's probably not a true postpartum psychosis. These women oftentimes will have symptoms as early as day 3. They look too good for having just had a baby, okay? They are excited, they are elated, they haven't slept. Life looks great in that room. And so when I call to check up on them and the nurse says, I don't know what you're so concerned about, Dr. Wichman, this patient looks really good. She's talking really fast, she hasn't slept a lot, but she's got it under control. I'm thinking, no. Rule number 1, all mamas have to be hot messes, okay? So if she looks too good for having just had a baby, that's a red flag for me as a psychiatrist, okay? So what are some factors that are associated with having an increased risk of a perinatal mood or anxiety disorder? So some of these are fairly intuitive. Lack of social support, marital discord, living alone, having an unwanted pregnancy. Our younger teenage population, that risk where I said 1 in 7, 1 in 4 for our teenagers. Much higher risk for our teenage population. Multiple children. So it's particularly if you've got a mom who just had a baby within the last year. She has a second pregnancy prior to that first baby's first birthday. That's a risk factor for perinatal mood and anxiety disorders. Certainly if they have a personal or a family history of affective illnesses. That just makes some good sense too. On the other hand, though, this discontinuation of an antidepressant. So it's not uncommon. We see this all the time, where moms find out they're pregnant and they stop everything. Not just their mental health medications, they stop everything, thinking that they don't want to put baby at any risk or harm. So what we see, however, though, is almost 70% of moms relapse if they discontinue their antidepressants at time of conception. Okay? That number is still fairly high, even if they continue on their psychiatric medications during pregnancy. But it's less, obviously. So about a quarter of women will relapse, even if they remain on their antidepressants. So what I tell women, what I tell anybody who will listen to me, is that when you find out you're pregnant and you're on an antidepressant, you're on a psychiatric medication, your first call is to your provider to have that conversation. Is this an appropriate time for you to come off medications? Maybe it is. Maybe that mom's already been stable for a year and it's an appropriate time for her to taper off given her period of mood stability. But if she's only been doing well, or maybe she's not even well yet, Probably not. The risks are too high for her to have a relapse during that time. What are some red flags that we look for? Not just myself as psychiatry, home visitors, our OBs, lactation consultants, social workers. These are all things that we can be looking for. I have 3 children. I am not deluded to the fact that moms will be sleeping well. Like, that's not what I'm asking. But if they're unable to sleep when the baby is sleeping, babies sleep a lot. I don't need moms to be sleeping 18 or 20 hours a day. But if it's 2 a.m. and that baby's asleep and fed and tucked in, and that mom is laying there wide awake at night, that's a red flag. Right? If she wants to sleep and cannot sleep. Pre-pregnancy weight, if they're below their pre-pregnancy weight by that 6-week visit, that may be a red flag. Took 9 months to get it on, probably should take a few more weeks than that. There are women that naturally go back down, and I get that, but at least it's a flag to ask some more questions. Are you eating? Okay? Do you have an appetite? Again, some of those questions can help give you some clues on how she's doing from a mental health standpoint. Loss of interest in self-care. I really appreciate the insight of the home visitors that I work with because they're going into that home and seeing what things are looking like. Has she showered? Just asking the question. Sometimes women come into my room and they're in pajamas and slippers and I wonder, and I just ask, when was the last time you showered? Like, how are you doing? How are you caring for yourself? Women should still be showered nearly every day. Nearly every day, right? If there's any evidence at all that the baby's not being cared for, this can be subtle. If women are coming all the way into my office and they've managed to get to my appointment on time, they're probably doing pretty good, right? So that's a kind of a select group. But if that, even things as subtle as that car seat being faced towards me and not towards mom, or if that never checking on that baby during that 30-minute follow-up appointment with me and not showing any interest, again, things that I'm cluing into, things that all of you can clue into as well. Social isolation. I also have a rule. I recognize we live in Wisconsin. It's cold outside, but you should be getting out of that house at least 3 times a week. All right? It doesn't have to be momentous occasions. It can be a Target run, and that's okay. But trying to figure out how to get mom out of the house, because if she's getting out of the house, she's probably doing some self-care. She's got a goal of where she's going. All of those things can be really helpful. So if mom is saying, I haven't had to leave the house. I've got Amazon, Prime delivering everything I need. My husband's taking care of the other baby, and she's holed up, and you start to wonder what's going on. And then certainly if she's expressing any symptoms of depression. Right? A lot of our moms don't do that, and so we need to be looking for other clues to then ask more questions about. Suicidal ideation probably scares a lot of you in this room. Doesn't scare me. That's okay. I've done this job for a long, long time. So some clues for what you need to be concerned about versus maybe not so much. So 3 things need to happen. 3 things need to be in place for a mom to be deemed, quote unquote, imminent risk. So in the state of Wisconsin, we have an emergency detention. So a police officer, custody comes and evaluates somebody, and for them to be put on an emergency detention for a psychiatric hold or evaluation against their will, they need not only to have suicidal thoughts, they need to have a plan, and they need to intend to follow through. All 3 need to be present. If only 1 or 2 of the 3 are present, that patient is not deemed to be at an imminent risk. We're not saying that they don't need help soon, but that bring them directly to the emergency room may actually cause more harm than good from a rapport standpoint. Women who are at lower risk, they've had no prior suicide attempts. They have no plan, they have no intent. A lot of these women will say, I've thought about suicide. I thought that my baby would be better off without me. If I got hit by a bus today, that would be okay with me. These women are probably at a lower risk of, or are at a lower risk of suicide than that other side. If they're able to tell you why they haven't acted on the thoughts, and asking the question, having that difficult conversation, just asking, what has prevented you from acting on those thoughts? That's a perfectly legitimate question to ask. Studies have shown time after time that if you ask specific questions about suicide, that will not increase that woman's risk of suicide. Okay? Asking her what's keeping her from acting on it. Higher risk, the #1 risk factor for a suicide attempt is a previous suicide attempt. And so that's the highest risk factor. Particularly high lethality. So if a woman's overdosed on acetaminophen or utilized a firearm, absolutely. very concerning. If she's got a current plan, I plan to overdose on the Valium that's on my kitchen counter, and she has intention of doing so, some women will absolutely say, I thought about doing it, I kind of intend to do it, I just don't know, and I can't tell you why I haven't. Those are women who need immediate help right then and there. We talked a little bit about assessing thoughts of harming baby already when we talked about intrusive thoughts. Again, that's the vast majority of the thoughts that I hear from women about thoughts of harming baby are anxiety in nature. So these are those intrusive thoughts of an anxiety disorder. Those thoughts are intrusive, they are scary, they distress that woman, and she recognizes that she should not be having those thoughts. Those women will go to great lengths to not harm their baby. And in fact, I've never had a woman who's had an anxiety disorder and intrusive thoughts of harming her baby actually harm her baby. Those are the women who will go away, will avoid their babies because those thoughts are so distressful to them. On the other hand, thoughts of harming baby that occur secondary to psychosis, primarily postpartum psychosis, those women do not have insight into those scary thoughts. They are not scary to them. They don't see them as problematic. They oftentimes are going to be having other psychotic symptoms, hallucinations, delusions. They're paranoid, they're suspicious, they're maybe very guarded in what they're telling you. Family members are picking up on this, absolutely. Okay, those women, if you actually are able to understand that they're having thoughts about harming a baby in that type of patient, those patients need to be psychiatrically hospitalized immediately as well. So how do we have these conversations about mental health? Part of my job for the last several years has been educating non-mental health providers to be able to do exactly what I'm talking about right now. And that's not diagnosing, that's not managing, but being comfortable in asking the right questions. If you're able to ask the right questions, then you're going to be able to guide that patient, that mom, that client into the right treatment options that they need, or at least guide them to the right provider at the right time. My number one rule is that the conversation that you may be having is only difficult if you perceive it as difficult. Okay? Women, patients, children, everybody will pick up on your anxiety. If you stutter, if you stumble, if you have that anxiety about asking these questions, women are going to be much less likely to disclose to you. I've got this great clip of a woman telling me about her, telling about her anxiety disorder in the postpartum period. But because her primary care provider really stumbled on asking the right questions, that really played on her anxiety. And she can tell the story beautifully. She's like, but because they're wavering on how to ask me the right questions, and they're wavering on my treatment, played on her anxiety even more, that she became really distrustful of that provider because they didn't know how to ask the right questions or to give appropriate management and referral at that point. So it's really important to have that confidence and recognition that with practice, these are questions that I hope all of us in this room can be able to ask. Again, I'm not asking non-mental health providers to be diagnosing and managing mental health disorders, but asking the right questions to get your clients to the right help. That's all of our jobs. I truly believe that. And certainly these principles can be applied to other difficult conversations. So I've been utilizing perinatal mental health as kind of a framework and talking about some of this, and you'll see some of that in those role plays. But these same principles can be applied to other difficult conversations. What are other difficult conversations that we have? Let me yell out. Sex. Nobody wants to talk about sex. Yes. What else? Periods. Menstrual cycles. What else? Substance abuse, tobacco abuse in pregnancy. Absolutely. What else? STIs. Keep going. Domestic abuse, domestic violence. Absolutely. What about terminations, abortions? Miscarriages. Absolutely. So these same principles can be applied to any of these other difficult conversations. Okay? So recognizing, so we're going to be talking about kind of the guiding principles that I utilize. Again, using mental health disorders as a framework, but really can be applied to other things as well. All right. Very simple principles. Very simple principles. Building a relationship, rapport, trust. These are things that are often built over time. You may not have the opportunity to be able to always do that. And so disclosing up front about why you're asking the questions that you're asking can be incredibly helpful. You're coming at a woman and you're giving a laundry list of questions and she doesn't know why you're asking these very personal questions of how they may impact her care or your relationship with her. That can be really distressing. And so framing the set of questions that you have can be incredibly helpful. So again, for perinatal mental health disorders, I know that 1 in 7 new moms will struggle with depression and anxiety. And I know that the best way to get women the help that they need is by screening every single person. And so every new mom that comes that I have interaction with, I ask the same set of questions or I utilize the same screening tool to make sure that we're not missing anybody. So again, 1 to 2 sentences to frame the questions that you have, but you can have that same introduction to any of these other topics that we just had. Normalization, non-judgmental, you make it routine, okay? So again, I do this with everybody. This is not different because you are smoking. This is not different because this is your 5th baby with 4 different fathers. Whatever the case may be, this is the consistent with everybody. Studies show consistently that if you sit down, you face the patient, they are much more apt to have a more open and honest conversation with you, and that patient's going to perceive that you're spending more time with them. Okay, so if you work in a hospital setting or a clinic setting, walking in and standing over or standing up, patients perceive that you're spending up to less than half the amount of time with them than you actually did. Okay, so again, that may not apply to everybody, but if it does, take the time. I actually make a big show of it when I'm working in the hospital setting where there may not be ready seats, dragging in a seat, sitting down, taking the time, putting away materials. That's the other piece that I try to teach everybody. You'll remember these conversations, especially if you have the opportunity to go document right away and write it down later or immediately after. Having a notebook or something in front of you and taking notes so that the patient's seeing the top of your head, not real useful, okay? Put it aside. I always tell my students, you guys are always going to remember the details. It's okay. Put it aside, have a conversation with your patients. Utilization of a validating screening tool is incredibly important. And there are screening tools for a lot of the things that were kind of just yelled out, or at least having a set of questions that you ask every single patient. When you talk to OBGYN providers or you look at the research, the vast majority of OBs will say that they are screening for postpartum depression. Absolutely, I am screening. What are you doing to screen for it? They say, I ask, how are you doing? Not so great. Let me tell you, not so great. So it has to be more than either just a very too broad of an open-ended question. What we see consistently is utilization of a validated screening tool. So we certainly have those in mental health. We have those for alcohol use. We have those for tobacco use. Utilizing a similar set of questions that you use for every single patient can be incredibly useful. And then following up after that screening tool. So it's not good enough to have the mom do a screening tool, have her complete it. What happens in my clinic all the time is that our MAs or our nurses may score it, put it into the medical record, and the provider never sees it, and it's never actually addressed with the patient. So if you have the opportunity to actually do a screening tool with the patient, take the time to go over that score with her, tell her what it means. It doesn't have to take a long time, particularly if it's quote-unquote normal score. The other piece is that a normal score, she may have 1 or 2 very elevated items on that screening tool. But then you can have the opportunity to say, you know, your score here is within normal range. Tells me that you're probably doing okay, but I see here that it says that you're really anxious, and maybe that's the only thing that was elevated. Can you tell me more about that? Tells me here that you are not sleeping well. Tell me more about that. What's going on? So utilize those screening tools to your advantage to really open up that conversation. Okay. I do not have. So this is a video that we made for the Periscope project to teach OBGYNs and other providers who are caring for postpartum women how to take advantage of these opportunities. Okay, so it's about a 5-minute video.
One of the reasons why Mom's Mental Health Initiative wanted to pair up with the Periscope Project is because we firmly believe that the quicker a mom receives treatment, the quicker she can feel better.
You can make a difference by having these conversations with your moms, each and every mom, because you don't know what that mom is struggling with outside of your office setting.
I visited my OB for some physical issues, and I told him how much I was struggling, and I remember I was sobbing in his office, and he looked at me and he said that he didn't think I had postpartum depression and anxiety and that I should really just give it more time. And it kind of made everything worse.
A mom is walking into your office with so many fears and so much anxiety about how to let her doctor know what's going on.
I'm just going to take a look here at your information.
Okay.
I'm just running a little late. I've got like 3 patients I'm behind on. So.
They're terrified about what they're experiencing, but they also don't want to be a burden.
All right, so it's been about 6 weeks.
Yes.
All right, very good. So I'm just going to ask you a few questions. How are you doing? How's everything going?
Nonverbal communication plays a huge role.
Okay, I guess.
Okay, all right. Any pain?
No,
No?
physically I'm doing fine.
Okay, physically you're doing good. All right, good. Any other problems or issues?
Well, actually I'm a little concerned that I might not be adjusting to motherhood very well.
Really, how?
I'm just having a really hard time sleeping.
Hard to, well, that happens all the time. That's normal.
Yeah.
Yeah, just give it a little time. It'll get better. It always does.
They don't want to be that mom that's always complaining. They don't want to be that mom who is looked at like she's crazy.
Any other issues or problems?
No.
Your mood's pretty good?
No, but I guess that's normal, right?
Oh, well, I mean, yeah, you're not getting sleep. So if you get a little more sleep, your mood will definitely improve.
Okay.
Okay? All right.
A mom going through this just feels completely alone and that nobody gets it. And honestly, many women think my family, my child would be better off without me.
So anything else?
No,
Okay, I think you're doing great.
thank you.
You're welcome. We'll see you later, okay? All right.
At my lowest point, I had hit this point of complete hopelessness. I thought that I wasn't going to get better. There was no helping me. I felt worthless as a mother. I felt worthless as a wife. It got to the point where I actually thought that the only way I could be a good mom was by killing myself, because I thought that my baby would be so much better off if I wasn't in the picture.
Providers can show concern by creating an open dialogue through each visit with their mom.
Everyone should be screened and everyone should be having these conversations. The issue is then what do you do when you have a positive screen? And the Periscope Project really tried to fill that niche by being able to provide support to our frontline providers.
It's good to see you again. It's been about 6 weeks, huh? Okay, well, how have things been going?
Having a provider take the time to sit down facing her, asking her specific questions about her mood, anxiety or worry, and sleep. They paint a very clear picture from an emotional standpoint.
Okay.
Okay. I know that you filled out a Edinburgh test for us.
We always advocate for validated screening tool. And the reason is because we can't always see.
And I have your results right here, and you scored really high on it, very high on it. And we don't typically see that. And so you say that you're doing okay, but are you sure you're doing okay?
And we know that 15% of women will struggle with perinatal mood and anxiety disorders. So while it's not normal to struggle, it's certainly not a rare occurrence.
Well, I feel like I'm not really adjusting to motherhood.
Okay. Can you help me understand that a little better? Like, how are you not adjusting? Is it You're not getting enough sleep?
No, I'm not getting enough sleep, but I feel on high alert all the time, and I'm having these episodes where my chest gets really tight and my heart is just racing and I'm having a hard time breathing. It doesn't feel natural, and it almost paralyzes me. And
How long have you been having these for?
since my baby was born.
I can tell you're hurting, and this score plus these panicky attacks, they've had me concerned.
Providers can communicate to their moms that this is a disease and to speak up if they feel like they're experiencing any of these symptoms.
We have this service that we've become a part of. It's called the Periscope Project. I can give them a call with this information and kind of figure out a plan, because this is a little out of the realm of my expertise.
One of our biggest goals of the Periscope project was for ease of use. We really structured our program to be very timely and responsive to the needs of our providers. The Periscope project puts subspecialty psychiatric consultation at your fingertips.
Now, postpartum depression, like I said, it's not typical, but it does happen. It is common. You're not alone. And with this Periscope project, I can get you the help that you need.
They're trying to feel better and pointing them towards treatment. The quicker she can feel better.
So I just need to give them a call really quickly. I'll step out for a few minutes. I'll come right back, and we'll have a plan in place and maybe even a referral, okay? All right, great.
Providers can be the difference.
We've got great evidence to show that maternal mental health impacts not only mom, but her family and her children.
We're asking providers to talk with their moms about this at every visit so that the mom can have the language and the tools and the knowledge to speak up and speak out when she's suffering.
Anyone who is interacting with pregnant women and postpartum women who may pick up on concerns about emotional health, we're willing to have conversations and help these providers help the patients that they're serving.
Did we get the gist? So if we would have been able to continue on with that video, the second video was actually the same provider going through that same scenario. He had actually had her complete a postpartum depression screening in the waiting room, went over it with her. Again, the whole conversation took about the same amount of time. So Dr. Iqbal, bless his heart, I love him. He's a practicing OBGYN who then came back and is in the midst of doing psychiatry residency because perinatal mood and anxiety disorders were so near and dear to his heart that he wanted to be able to be dual, to be able to do that. But he's like, this is, when I asked him to just plug an OB and to put all of his psychiatric training aside, he said that's actually really easy because that's exactly what we do. That's not uncommon. And we all kind of laugh and giggle. He's like, that's exactly. I had 20 patients to see in a half a day. It's not uncommon for me just to kind of push aside some of the concerns that a mom may have, or I might not even recognize it. So that, again, I agree, it was obviously an over-exaggeration, but in his reality, from a practicing OB standpoint, it's actually not that terribly far off.